Dr. Keith Cheng is presently an Associate Medical Director of Behavioral Health at CareOregon. He's also working at OHSU, where he serves as the Medical Director of the Oregon Psychiatric Access Line, OPAL, and the Project Echo Child Psychiatry Training Clinic. After completing his child psychiatry fellowship at the Yale Child Study Center, Dr. Cheng has devoted much of his time to academia and education. He is co-editor of a child psychiatry textbook and has developed child psychiatry training curriculums for OPAL and ECHO programs. At this time in his 30-year career in Oregon, he is devoted to the support and education of primary care clinicians so they can provide psychiatric care in the medical home. Please join me in welcoming Dr. Keith Cheng.
Hi, this is Keith Cheng. It's my pleasure today to talk about two programs that I'm very much part of and would like to share the details about these programs with you today. So today we're going to talk about the Oregon Psychiatric Access Line and two other programs, the ECHO Clinic and the foster care program that goes along with the Oregon Psychiatric Access Line. Here's a picture of our website. And why are we talking about these two programs that support the medical homes in Oregon? One is there's a huge challenge for providing mental health in Oregon. In the Pacific Northwest, there's a shortage of child psychiatrists. There are long waiting lists to see them. There's high rates of untreated mental health issues, and suicide rates have not only stubbornly been unchanged, but actually getting worse during the past 5 to 10 years. And as we know, many suicides are secondary to unidentified and untreated depression. Why do we need behavioral health care in the medical homes? Well, patients and families often feel more comfortable and trusting of primary care providers. Primary care providers have the opportunity for prevention and screening. Primary care providers know the developmental and family context of symptoms. Addressing psychiatric issues in primary care settings can reduce stigma. So there are possible solutions to child psychiatry shortage. One is to increase the number of child psychiatrists trained. Another is to co-locate child psychiatrists within the medical homes. And then there's also phone consultation programs that have been used, I think, for the past decade now at least, and child psychiatry training programs like Project Echo, and e-consultations where primary care clinicians can email questions to subspecialists like child psychiatrists and get information referred back to them in emails so they can look at it at their leisure. But for today, we're going to talk about the Oregon Psychiatric Access Line about kids, the OPAL K Foster Care Project, and the Child Psychiatry Echo Training Clinic. So the goals of OPAL K is to reduce the number of children who do not receive treatment for their mental health challenges, decrease delays in treatment, target appropriate levels of intervention, utilize a biopsychosocial framework, and improve appropriate prescribing of psychotropic medication. Now, the OPAL K program was created in partnership with the Oregon Pediatric Society, OPS, the Oregon Council of Child and Adolescent Psychiatry, OCAP, and OHSU. It's currently a state-funded project that started in 2014. OPAL K is based on successful programs started in Massachusetts, or MHPE. The Massachusetts program actually started back probably around 10 years ago and is viewed as the granddaddy of all phone consultation programs. Partnership Access Line in the state of Washington, we actually partnered with them to develop the OPAL K data website, and there's currently over 30 different child psychiatry access programs in the United States, and we're all supported through the National Network of Child Psychiatry Access Programs. Now, before we got started with OPAL K, we did some outreach to let people know that there was going to be a phone consultation line available. And these little red dots here on the map show you all the places that we actually made in-person connections with primary care clinicians and offices. And as a result of our intake process, we had many people registered to be part of the Opal K project. And so here's how it works. It's pretty simple. Same-day phone consultation with a child psychiatrist, evidence-based practice data to support primary care clinicians in need of mental health diagnosis and treatment informations, and practical advice to clinicians and care guides for common mental health challenges. So where are these calls coming from? They're primarily from urban areas by number. Here's a sample. But if you look at the rural percentage where it says only 20%, when you do that per capita in terms of youth in those areas, rural areas actually have more consultations per capita. So for example, here we are, these are consultations per 1,000 children. And you can see Gilliam County in this particular sample has the most. Coos County, Clatsop, Hood River, Lake. These are all either outnumber or similar to the Multnomah County calls, which again by number of calls per 1,000 youth, 0 to 18 years. The age distribution of calls is bimodal. The green bars are female, the blue bars are male. And this bimodal distribution shows that in school-age youth, we get more calls about boys, and it usually has to do with externalizing behavior problems such as ADHD or oppositional defiant disorder. And in teenage females, we get more calls, and it's usually about depression and suicidal behaviors. So what are PCPs calling about? Well, on the big pie graph there, you can see there's 3 major pieces there. Anxiety disorders, neurodevelopmental disorders, which is basically ADHD, and depressive disorders. The green piece on the big pie graph shows trauma and stress-related disorders. And the gray piece shows other diagnoses that are also asked about in Opal K calls. So what happens after there's a consultation? Well, the majority of cases are kept in the medical home where the PCP continues care. Very often, therapy appointments are recommended. As we know, treatment for most psychiatric disorders is more effective when combined with medication and psychotherapy. And then there's a fair bit of care coordination going on. This pie graph shows that by and large, primary care providers are doing a good job asking about trauma. When we make a phone call, we always inquire, do you think some traumatic event has anything to do with why this youth is having behavioral symptoms that you're calling about today? However, there is a small population of PCPs who don't ask about trauma. And when we check to see if they start asking about trauma, lo and behold, we feel that the Opal K program actually can change behavior of primary care doctors in terms of their review of systems. So in the sample of 100 callers who initially did not ask about trauma in their calls, in subsequent calls, 86% of them were noted to be asking about trauma. And of course, this is a good thing as trauma is ubiquitous in our populations. Here's some data about Opal K calls and suicide history. Again, we're hoping for the same thing to happen for suicide history, that for those PCPs who don't ask about it, which again is a very small slice here, only 3%, we can see the same improvements in asking about this on review of systems that we had in trauma. After a Opal K consultation call, well, the consulting child psychiatrist creates a summary. And in the summary, we outline things that were discussed during the call, including non-medical interventions, psychosocial treatment advice, medication management considerations, how to monitor for progress, and other comments germane to the case. In addition to the call itself, we also have created some mental health care guides. kind of like mini reference information for primary care docs. On the cover here, you can see this one is for depression. And we have care guides developed now for depression, ADHD, anxiety, psychosis, bipolar disorder, sleep problems, and aggression. And we have several under development here too. In the care guides, we provide an evaluation and treatment flowchart. So the first page in a care guide is a diagram that shows how evaluations precede treatments and the things to watch out for. We also have the flowcharts followed by specific evaluation guidelines written down in terms of providing pearls of things you should remember when you do an assessment. For example, in ADHD, how important it is to get rating scales, not only from parents, but teachers too. We have copies of rating scales that you can use in your practice. So you can download these from a link in the care guide, or just copy them if you printed them out. And if the rating scales are not available for us to actually copy and put in the care guide, we also leave you links where you can download them for free. There's a treatment guidelines section, again, specific pearls about what to look for when developing treatment plans. A medication flowchart showing which medications you may want to start out with for your specific psychiatric disorder, and what to do if your initial medications don't work. So first, second, and third line medications are listed there. There's a medication table, which is great. It lists the forms medications come in, the dosages, initial dosing, maximum FDA-approved doses, and side effects to watch for. There's also cost information in these medication tables, which allows all clinicians to share the responsibility of stewardship for trying to look and see how much cost may play a role in your treatment choices. The family checklist is another document that's one page that can be used by a primary care clinician to assist in the treatment of mental health disorders. The checklists all have 4 sections, one for parents, one for schools and teachers, one for siblings, and then one for the patient. And these are all things that can happen in the homes, and you can review these checklists with the families and the patients during your visits. For example, in the depression checklist, one of the things for the parents to do is make sure to remove weapons from the home, because obviously there's an increased risk of suicide with depression. And you can check in with your families about this. The family resource list lists both online and in-print sources of information on various psychiatric illnesses. There's also a clinician resource list, again with links on the web to the web that you can use to get the latest information for the disorder in question. And finally, there's a bibliography available for people who are really wanting to get in-depth information. So far, total enrollments are about 2,000 for Opal K. For Opal A, we have about 691 enrollments, in addition to the 1,928 that have already been enrolled from Opal K ranks. Thus far, we've got well over 3,000 consult calls since inception in June 2014. Opal A just started in October 2018, and we've already got 1,000 consultations completed as of May 11th. Foster care reviews, which we'll go into in depth shortly, we have provided 279 consultations. And pharmacy case reviews, another separate program, we've done 79 cases where we're looking at the use of antipsychotics without FDA indication in kids 10 and younger. In general, the Opal K monthly call trends are going up. As you can see, we're in the blue lines, these are urban calls, and in the green line, the rural calls. Both of them show trends upwards. So as time goes by, we just expect more and more calls to be coming in as people become familiar with this service. Post-survey data shows that most clinicians find Opal K extremely helpful. Here are some of the items here where they strongly agree that they find Opal K consults to be useful, that they're able to connect with consultation in a timely manner, they're satisfied with the process, they feel their patients are receiving mental health assistance more quickly, and they're better able to care for their patients after consulting with Opal K. And maybe most importantly, they're more comfortable addressing mental health issues in their practice, knowing that they have consultation available. Post-service surveys, again, reflect positive reviews for our program. One clinician from Jackson County states, could not function as a primary care pediatrician anymore without Opal K. Access to skilled child psychiatry consultation allows me to more effectively address the growing mental health needs of our clinic's pediatric patients. You know, additional service we provide that we've alluded to is looking for improving appropriate use of psychotropic medications for youth in foster care. During the last couple of decades, foster care kids, by and large, get prescribed more medications and more off-label medications as a way of managing difficult behaviors that perhaps shouldn't be managed with psychotropic medications. As I mentioned earlier, we have a pharmacy project with Oregon Health Authority looking at the use of antipsychotics in youth 10 and 12 and younger. We also periodically consult on outlier cases with providers, and we find that these have been very useful to assist primary care doctors who get, I believe, you know, kind of cornered in these really complex psychotropic medication regimens where with simple support, they don't have to feel, they have to keep prescribing like large amounts of medication. And we'll talk about that in some of our cases later. So what happens in Opal K consultations? I'm going to give you a case vignette. A 6-year-old boy who was referred to primary care for a prescription of Ritalin. This youth and his family recently moved from Oregon, from California, to live near relatives. There's a family history of depression and anxiety, but not ADHD. And in this particular call, the primary care provider was on his 3rd trial of stimulants. And if anything, the youth was doing worse on stimulants. And they were wondering what to do. Well, one of the common situations we run into on Opal K is where youth are being treated for ADHD when it's actually PTSD or trauma related. And if you think about it, a lot of the symptoms for post-traumatic stress disorder overlap with ADHD symptoms. For example, kids who have severe PTSD have really a difficult time concentrating. They're easily distracted, and they're frequently so agitated they appear hyperactive. And primary care clinicians will be frequently asked by schools and teachers to place a child on stimulant medication for ADHD when actually it's trauma that's driving the behaviors. So in this particular case, we find out that while in California, this 6-year-old boy was actually escaping a neighborhood where there was a lot of gunfire in the next door neighbor's house, and it was very traumatizing for this child, and he developed PTSD. So when he came to Oregon, it was quite difficult for people to discern with that maybe the ADHD symptoms that were being seen were actually from trauma. In Oregon, he was living in a nice neighborhood where there were no longer gunshots, and people weren't thinking about the past trauma that could be driving the ADHD symptoms. Well, let's now turn to the Opal K foster care project. The main goals here is improving the appropriate use of psychotropic medications for children and youth in foster care. And as mentioned earlier, these youth frequently get prescribed more psychotropic medications than youth who come from intact families. The foster care project goals include improve the effectiveness of the consent process for psychotropic medication use, expand collaboration among stakeholders in this quality improvement project, improve the safety and effectiveness of psychotropic medications use through the utilization of best practices and evidence-based information, and reduce the use of antipsychotic medications for unapproved indications. And finally, reduce polypharmacy use for most of the youth who are on 4 or more psychotropic medications at one time. To address these issues, there are 3 main strategies. One is psychoeducation, and psychoeducation includes educating the youth taking the medication, the guardian or the caseworker from DHS, and the clinicians who are prescribing medications. There's a rigorous consent process as part of this strategy to make sure that everyone has the information they need to make the best choices possible. And then improving clinical practice by giving feedback to primary care clinicians who've been identified needing support for these difficult foster care cases. So as far as information is concerned, the creation of tip sheets written in language that youth can understand give the kids a better idea about why they're taking the medications and what to expect from them. They also are educated about, their responsibility or their assent in the process of taking medication. And so this is very worthwhile for the youth. Here's the tip sheet that was created, the Psychotropic Medications Guide for Youth in Oregon Foster Care. And again, it mentions the categories that are considered high risk, if you will, for side effects. And again, including doses higher than the FDA approved maximum dose of medications, taking double medications of any particular psychotropic medication category, taking 4 or more medications, using medications for youth less than 6 years old, and in particular looking at the use of antipsychotics and other psychotropic medications without FDA-approved indications. Now we do the same thing for foster parents. There's the medication tip sheet for them, but we also try to help them understand better the trauma that's experienced by foster kids, that perhaps by using other methods that the reliance on psychotropic medications isn't so great. So there's trauma training that goes on. CPS stands for collaborative problem-solving training that goes on. And frequently, when foster families and DHS foster care workers understand better trauma, they're making referrals for treatment with medications decrease. I mean, in the past, I can remember foster parents coming to the office and asking for medication by name. For example, there was a case where a family wanted for their child Abilify and Ativan, and they asked for these medications by name. And when the psychiatrist said, there's really no indications for this, the culture of using a pill was so strong that they actually went to the Multnomah County Board of Supervisors and complained that the psychiatrist wasn't listening to them because they weren't prescribing these medications. So again, education for the foster parents is key to change this culture of using medications for trauma. And here's the tip sheet for caseworkers and foster care parents. For the DHS staff, again, they would also receive trauma training, CPS training, and then the development of tip sheets hopefully will help them understand better the reasons for using medication. For clinicians, dashboards have been created that are going to providers and CCOs, showing how they match up in their prescribing practices versus their peers when it comes to taking care of foster care youth. And some CCOs are already using this data for quality improvement projects. Trauma Informed Oregon has also been focused on training primary care clinicians using evidence-based guidelines. And in fact, hopefully next year, 2021, in consultation with Trauma Informed Oregon, we're developing a trauma echo training clinic to address those issues, as well as getting trauma-informed care from OPAL-K consultants who work in the regular program. And as noted earlier, there are OPAL-K guidelines. They've been vetted by the Oregon Council of Child and Adolescent Psychiatry, and they're on the website. A lot of clinicians find these very educational. And the providers are actually sometimes given these guidelines after calls. We just check a box and they send them along with the call summary. So here's an example of a document from the Department of Medical Assistance Programs. This particular slide shows a graph there that shows, for you as a clinician who receives this, how your prescriptions of medications compare with child and adolescent psychiatrists and neurologists and other Medicaid patients. So good perspective. And then here's the dashboard. It's small to read here, but children on antipsychotics without a screen, metabolic screening, we'll talk more about that later. 5 or more concurrent meds, 3 or more concurrent meds, under 18 on any antipsychotic, 5 years and younger on psychotropic medications. These are all being tracked. And here's the handout that gets sent to people where a youth may have been on antipsychotic medication and nobody's bothered to do any metabolic screening for over a year. And so this is to help people understand that there's actually national standards for this. And they also include getting family history of diabetes, looking at weight, waist circumference, blood pressure, fasting, blood glucose, and lipids, all which are what are considered national standards for anybody being on an antipsychotic medication. We talked about a rigorous consent process. For kids in foster care, not only does the caseworker become involved in the consent process, but the supervisor of the caseworker have been reviewing these consent processes. And so they take extra time deciding based on the tip sheets they've been giving and the education they've been getting of whether or not the psychotropic medication prescriptions are appropriate for their youth. And as far as clinical practice, we've talked about this already. Those dashboards will help primary care clinicians who've provided 4 or more psychotropic medications at one time, 2 or more medications in the same class, antipsychotic prescribing without metabolic monitoring, and medication for children under 6 other than stimulants, and then the antipsychotics. Again, we're looking for under age 6, multiple antipsychotics, and then longer than 6 months without a FDA-approved indication diagnosis. So what happens if you get flagged as a case that needs review? Dr. Jet Milani at the Oregon Health Authority is the consulting child psychiatrist. And so when any cases are reviewed by the nurse they have reviewing all cases, they'll flag them for one of those 5 criteria mentioned before. And then Dr. Jet Milani will look over them. And if he sees something where he thinks is particularly concerning, he'll turn them over to OPAL-K for peer review and also for providing a consultation with primary care docs. So what happens when you do all of this work? Well, hopefully psychotropic medication prescriptions will go down, which this particular graph shows from 2012 to 2015. Same amount of time, 3 or more psychotropics has a general downward trend. On any psychotropic medication continues to have a downward trend. Under 6 years old, getting medications, a downward trend. So we're feeling pretty good that as part of the team on working to help decrease psychotropic medication use in foster care, we're doing a pretty good job. So here's an example of a case that we may have in a foster care consultation. 13-year-old female with chronic complex trauma and abuse, now in DHS custody permanently because the family, typically these cases are of parents who are drug addicted or drug addicted and making drugs, and as a result, the care of the child falls on the wayside, and they end up in DHS custody. This particular youth had recently returned from an out-of-state residential treatment. And then was presently in their 14th foster placement. That in itself was traumatizing, obviously. And the poor primary care doctor inherited the patient who was on multiple medications and felt like, well, I gotta fill these prescriptions because those were the discharge medications from this out-of-state residential program. However, this patient was on double antipsychotic, a stimulant, double alpha-2A agonist, and fluoxetine. That in itself is kind of worrying because you increase the risk of having really severe side effects like serotonin syndrome, or run the risk of causing a lot of sedation with the clonidine, the Zyprexa, the Abilify. At any rate, this particular primary care doc was dutifully, doing what they thought was best. They had just finished training, and after the consultation, they were very grateful that they were given some advice about, how can I change these prescriptions in a safe way, at the same time minimizing the risk for out of control behaviors that resulted in residential treatment in the first place. Well, now let's talk about the Project ECHO consultation clinics.
Project ECHO is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centers and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under ECHO, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project ECHO, changing the world fast. Join us at echo.unm.edu. Are you part of the ECHO?
The ECHO clinics were devised by a hepatologist named Sanjeev Arora. He's a hepatologist at University of New Mexico. And when he first started there about 20 years ago, he was very discouraged that his waiting time was 6 to 12 months. So in order for a patient to see him, they could well be in liver failure from hepatitis C, which was his specialty, having to wait so long. So he was thinking, if I could devise a way of helping people in the communities take care of these patients rather than sending them to a subspecialist like himself, that would be a whole lot better for patients. So the ECHO model is not a traditional telemedicine type of concept. As you can see here in the ECHO clinics, what happens is there's an expert hub team that treats and supports community-based primary care docs. And then as they get trained from the hub as a spoke, they can take more care of more patients with the specialty knowledge in their outlying rural and sometimes frontier communities. In contrast, traditional telemedicine is consult one case at a time, one clinician at a time. In the ECHO clinic model, the treating physician retains responsibility for managing the patient, while in the traditional telemedicine consultation model, the telemedicine doc is the one who takes over treatment of the patient. And so that kind of model really doesn't address the shortage issues as plaguing all of the nation for subspecialty health programming. So this graph also shows you why this type of expertise is needed. There's an increasing gap between medical knowledge and how much you can know. Even as a subspecialist, as a child psychiatrist, there are many areas where I don't feel like I'm the best or the most expert in. For example, I may know a lot about psychotic disorders, but I'm not so good with eating disorders. And so I'm a subspecialist, but in child psychiatry, we have eating disorders subspecialists. But by expanding the definition of underserved population, it drives us to say, how can we decrease the learning gap for these specialty situations by providing subspecialists to do the training? So how does this work? When you have team-based care that uses the 4 pillars of ECHO model, you can help primary care clinicians take care of what used to be considered subspecialized illnesses. Through technology, mainly through video conferencing, using force multiplication, which is training clinicians in a rural community, and then they can train other clinicians in their area. Demonopolizing knowledge using panels of subspecialty experts. You can expand the knowledge of the clinicians in outlying areas. So as mentioned before, the basic principles of the ECHO training clinics is to use video conferencing, share evidence-based or best practices for the illnesses in question, and then use case-based learning to master the complexity of cases. And so we heavily used the case-based learning approach in our ECHO training clinics. The didactics are based on cases. We ask all the participants to present cases in the ECHO clinic. And in that way, it's more real rather than going to a lecture and hearing a bunch of data about what are the criteria for making certain types of diagnoses, or here's the long list of medications to use. Because these cases are more complicated than that. There's psychosocial issues that need to be addressed. There's resource shortages that need to be looked at. There's simple things like transportation, social determinants of health issues like poverty, racial disparities that need to be addressed before you can even get to the treatment involved. And finally, web-based databases are used by the ECHO program to monitor outcomes and continue to do program evaluation and improvement. So when our ECHO started for child psychiatry, we're in our 3rd cohort right now. We take 1 to 2 months to recruit people for the launch of the lecture. And the announcement goes to all the primary care clinicians in the state. And then if you respond, you get a follow-up recruitment letter and a participation contract. In the ECHO clinics themselves, our goals are to improve diagnostic skills and improve case formulation skills, improve treatment planning skills, and improve treatment intervention skills, and how to use psychotropic medications. And a lot of times, this issue about improving skills is more of letting you know you already have many of these skills already, and just giving you confidence to make use of them. So again, the teaching process relies heavily on case presentations, brief didactic presentations that are prefaced with a case first. You get the expert panel discussions. We also break up the lectures with medication of the week presentations, and then online resources of the week also. And so here are some of the didactic topics that we've used for our ECHO training clinics. And it's interesting, some of the most popular topics are not the ones you would think of, like depression, anxiety, or trauma. People are more interested in non-medical interventions, using rating scales, and how to use psychological assessments in their programs. So the goals of our Project ECHO are to get more youth with psychiatric disorders treated in the medical home. And this is done by improving the diagnostic case formulation and triage skills in the primary care providers. We also improve psychotropic medication prescription skills, improve psychic trauma-informed care in the medical home, and then hopefully as the skills and confidence increases for primary care docs in ECHO training clinics, they'll be experts in their underserved area, and force multiplication will occur, helping others in the area become also more able and maybe even expert in taking care of subspecialty types of problems. When you're in the clinic, the agenda goes, we have a community meeting where we talk about what's going on in the communities, what are the hot topics to think about or talk about. Then we go into the didactics, the case presentations, the panel discussions, and we summarize the case at the end, and as well as we talked about before, medication of the week and online resource presentations. And here's a map of our first child psychiatry ECHO, and you can see here all these rural communities were being served by the clinic because there are no child psychiatrists by and large in most of these areas that you could refer any cases to. Now, let's talk about some of the cases that happen in our child psychiatry ECHO clinics. This first case is from the didactic, and we're looking at an 8-year-old referred to a primary care clinician and teacher for an ADHD evaluation. From the mother's point of view, this child looks just like my brother or his uncle who took stimulants. It turns out the mother was 41 years old when she had this child. The biologic father works at Intel. There were no history of obvious developmental delays that the parents could remember, though this child did have a bad viral illness at age 3 years. Social factors involved in this case. This youth didn't have very many friends, actually no friends at school. His teacher noted he was too much of a smarty pants, so nobody really wanted to spend time with him. Parents admittedly were indulgent with their only child. And the teacher said, he talks all the time, maybe that's why he doesn't seem to learn anything. Doesn't like letters from his grandparents because he cannot read them. On mental status, this child had good eye contact, was noted to talk a lot. He had a lot of repetitive phrases, like everything in the office was dope. He was bad at playing some simple games. Simon is this musical tones matched to light sequencing game, very bad at that. Anagrams, taking letters and making words out of them. For example, rat and cat, he gave him those letters. He couldn't arrange them to make the word. However, he was very good at telling jokes. He told multiple jokes during the session, and he was, he was able to entertain himself when taking history from the mother. So as far as butting in or not being able to concentrate on some things, didn't remind you so much about ADHD. So this case was presented to show people that even though you get a lot of ADHD referrals to primary care, we'd like our child to be placed on a stimulant. A lot of times it turns out not to be ADHD. And I think this is where we can help out primary care, is to widen their horizons on things to think about when they get a stimulant referral. This youth turned out to have a learning disorder, dyslexia. For example, the reason he didn't like getting letters from his grandparents is it was written in cursive, and that's a classic symptom of dyslexia, not being able to read in cursive. Of course, not being able to do anagrams would be another reason for suspecting a learning disorder, is that at his age, at 8, you should be able to put lots of letters together to spell words. And just because you talk all the time doesn't mean that that's ADHD. For this particular youth, he was kind of like on the high-functioning Asperger's or high-functioning autism scale, and that was another thing to consider. that people weren't thinking about in this particular case. Let's look at another case that was presented by actual clinic member, and we have to disguise the cases, of course, but they also have very troubling cases to present. And in this one, there's an 18-year-old high school senior named Mary Jane was brought to her pediatrician displaying signs of agitation and acute psychosis. Her classmates had noticed that her behavior had become increasingly bizarre. She had isolated herself over the past month. She began smoking marijuana at the age of 17, and since starting her junior year, and used it daily. Mary exhibited signs of paranoia, believing other students at her school were stealing from her and trying to poison her. She remained adamant that all her problems were rooted in the competitive environment of her high school, and that smoking marijuana aided in keeping her sanity. In a sense, she was self-medicating. So this was a case that was difficult because how do you know the psychosis wasn't coming from the marijuana, or maybe it was coming from a developing schizophrenia, or maybe it was a combination of both, where the youth exacerbated maybe a vulnerability to becoming psychotic or having a psychotic illness show itself by using the marijuana. And so again, these are the types of real life situations that get talked about in the ECHO training clinics. Well, that's the end of my presentation. Thank you very much for your attention. And again, feel free to give Opal K a call if you have any difficult cases, and feel free to sign up for the next Child Psychiatry ECHO Clinic. Thanks a lot.